done orthodontics before, so thank you very much, Charles, for giving me this opportunity. We met at the Pitié-Salpêtrière because I teach at Paris Diderot. I was sent to the Rouen University Hospital in Normandy now, not in Paris, and I'm very pleased to work there now. But anyway, I'm not going to talk about the condition of the Paris hospitals. So I'm very pleased to be here because I'm talking about a field that I don't know so much about. I've been learning lots and lots. I can see that you can you work on night eye just the same as we do. You have problems with oral temperature like we do, and we actually used your work to work in root canals. But anyway, I didn't want to talk about night eye because it's not my specialty, and my activity is mostly on pulp regeneration, maintaining vitality, and all the problems that it can lead to. And I had to find a way to get you to stay awake, and I decided to turn to some papers that I didn't know so much, at least that I wasn't so familiar with, and I read Angon papers of 1939, because those papers were not easy to find, but I really wanted to find what was done and what was used at the core of those papers, and they're really old ones. And I realized that on this topic, it was only a long time ago that people were interested in this, and very little is done in research today. So you'll see some very old papers. And I also realized that the research papers, especially for orthodontics, are actually very short. And I thought, well, why not? I'd love to publish in your papers because these are so short, they're very brief, there's a question and answer, everything is done and dusted very quickly, and it was actually really interesting to read this literature. You may not know it, for me it was completely unknown, and I tried to summarize the problems that you create in orthodontics and the one that we create for you. We now do regeneration, and I think that's going to lead to some problems, and you'll have to adapt to us rather than the other way around now. So first things first, I thought, first of all, what are the repercussions? Because when we say a tooth for a patient, it's a tooth, and we say, well, you've got endodontics, the restoration, the orthodontics, and so on. Well, a tooth is a complex body, and for it to make sense, I had to go and see what influences we could have one way or the other. So I'll try and see whether the forces that you apply, the movements that you apply, have some clinical repercussions. And at a time when we didn't know anything about all this, I was just studying type plates model in '94, and I was really, I felt that I didn't know enough about orthodontics, and now I think that I've got to study orthodontics a little bit more and to up my game, and especially my research opportunities. Now, for root resorption, you know that they exist. They're often after the orthodontic treatment, and I was wondering if that's because of the orthodontic treatment, or if it was there anyway and it's just awakened by the treatment, and if it's a iatrogenous resorption, and which is actually caused by you. So you're a bit of our victim. Sometimes we say to the patient, have you had orthodontic treatment? And they say yes, and I say, well, that's it then. That's the problem. And I know really deep down that it's not the case in 3/4 of cases, but what else can we say to the patient? We have to say something. So then we send them back to you. And then you've got orthodontics and traumatology. You work on young patients. We see them, and sometimes we work together with you. So we had aplexification, immature tooth treatment, where we had to leave the calcium hydroxide for the whole patient. I'm not going to go into this, but what happens when you have trauma during treatment and vice versa? Can you do treatment on a traumatized tooth? And is that going to to influence things or not. And finally, and this is really where I'll be a little bit more at ease in my presentation, the new procedures that we are developing. It's not going to be a complete revolution for endodontics, but we are doing root canal regeneration, and we are starting to see young people that we treated 5 years previously. They're now coming for their orthodontic treatment, and I was wondering if the orthodontist can actually use those teeth and pull and bend and so on. So we'll see. So before all this, I just wanted to put endodontics where it belongs. If you're an orthodontist, it's probably a long time since you last treated a root canal, and generally you probably don't have a very good memory of it. If you went to orthodontics treatment, it's probably because you didn't like endodontics, and vice versa. My job as an endodontist, which I'm passionate about, is not just retreatment, it's not just putting gutta percha everywhere. And endodontics, our role as endodontists is to protect the bone on which you work. And I saw that you talk about degrees, about brackets, about hinge caps, about the 0, 1, 0, 2, and so on. And that's our problem. The problem is that the root canal is the only way the bacteria are going to come through there via the bone. So our responsibility is to stop bacteria entering this. So we treat sewers, basically. We put dams, we stop the leakage, and we do this when we have a pulp exposure. This is when we put a cap on the tooth. Then we go a little bit further to try and avoid going into the root canal. This is where I research if is this obturation, does that make sense? Well, my study is ongoing, and sometimes you have to close the door right at the bottom of the canal. So this is what endodontics is all about. It's not just root treatment. Then in the canal you have pulp. This is a pulp that I took a picture of before I slaughtered it. And then the question is whether the force that you apply on the tooth have a repercussion. We know that endodonplasts, these are the cells that produce the dentine, are immunocompetent. They capture the information, but also these are mechanosensitive cells. That means that all the forces that are applied to the tooth have an impact on the odontoblast. We don't know exactly how, but we know that there's an impact. The problem that I was confronted with in the ignorance that was mine in orthodontics is that there are different kinds of forces. You have the rotation, torque, traction, and all these forces are not going to behave in the same way, and they're not going to impact the tooth in the same way. And so limiting to just the pulp repercussion would be too restrictive, I would say, because I think you're a lot more aware and concerned by the repercussions on the ligament. You understand that, right? But there are repercussions on the pulp also, and we don't know much about this. Pierre Machetoun had given me this book, a very old book. This was the 3rd edition. Now it's been re-edited for the 6th time, and it's a 500-page long book on just dental pulp. And what Selzer and Belder were saying, they were the experts of pulp in the US, well, they said that from the time that you move, then you move the apices. And let's not forget that irrigation comes from the apices. So if you move, and it's the movement that you put on the teeth, the force, sometimes I see that the teeth have moved in 6 months. It's really impressive as far as we're concerned. Earlier, I saw a patient in 6 months, 0.02 or something, and I saw in 6 months you see the incisors back to its normal place. I thought, wow, the periodontum has to really keep track of this. And on studies on animals, we see that irrigation is a little bit all over the place following that. So if you have hypoxia for a few months, you'll see that you are not doing too well. If you are not doing so well as in apnea, then you'll see that air is actually very useful to live. We also see that there is an alteration of the sensitive stimuli. This is where the alpha fibers go in. They move, they pull, when you have orthodontic surgery as well, Dr. Dufresne, I think he operated my ex-wife, she was saying, well, I can't feel my chin. And I said, it's fine, you'll get it back. And she said, how long for? And I said, oh, go and ask the surgeon. She's very happy with the result, but she can't feel her chin quite so much. But anyway, I said that it was normal. When you pull on a nerve, you change it. Things change. It's a bit like when you take when you strip wires. Then if you touch them, it gives you some kind of feedback. If you work on young people, I think the limit is 16 years old. But when I started, it was 12. And we could see even 11-year-olds who would come, and we saw the teeth were immature for most of these patients, and the communication from the papilla, the epithelial cells, and the stem cells. That's where the endoton blasts come from, and if you pull them, they don't like it. So all this put together means that you get some deep changes, but we are not too sure about what it does. We've identified the cell issues, the overall issues, but we don't know what it can cause. In terms of the sensitive, we tried hot testing, cold testing, electric pulp testing as well. The hot and cold tests are you can see the teeth are very responsive, but for the electric test, they don't respond. But my kids, when they turn the thing, well, they are quiet for 2 days, and then after, it's as if nothing had happened. So there is a time when you activate things, and there you lost the sensitivity. You have a loss of sensitivity. The movement is quite brutal. I'm not an expert at all, but at that point, you have a sensitivity issue. But in the paper, they say, well, don't do electric tests because it's not reliable. Well, endodontists who said that the electric test was the best of tests, well, today, everybody says, no, it's a rubbish test. I hope you're not selling it here, but this is a test that is not reliable. Anyway, it means that you change the sensitivity. In terms of the cells now, if we turn to the cells, I remember that when I was in the UK, there was a gentleman who'd worked on this. He had forces with coils, and for the endodontoblasts, there's a degeneration of these cells. They die off, quite simply. And it's a shame because they produce the dentine. They're not going to have a pathology necessarily, but we see that there's a disparity of the endodontoblasts. But the pulp is continuing to live, and those are just one part of the pulp. It's not because the endodontoblasts die that the pulp dies, but when they degenerate, we don't know what happens. And one of the hypotheses, and here I don't have any hard facts, but maybe the degeneration would activate an osteoclastic route through the bloodstream, which could trigger the internal resorption, which we don't know much about. But we have to understand all that because the internal resorption is often directly linked to trauma or to orthodontic treatment. And sometimes the orthodontic treatment is like a mini trauma. You create mini traumas. They're controlled, and the results are there to say that, yes, it's worthwhile, but this trauma is controlled. And the responses are going to match this. And so we have a cell atrophy, and in histology, we see that some cells have exploded, have disappeared, and you have some holes in the cell matrix. These are just facts. We don't have any explanations. I don't think we have any clinical cases going on in this, and it's probably a shame. One of the potential explanations, which is not recent, it dates back to 1980, in the American Journal of Orthodontics, showed that there was a change of the breathing, of the respiration rate point of the cells. And here, they were comparing the different forces, the buccal forces and so on. And I think if you move the tooth buccally, or it's not going to be the same as if you just turn it around on its own axis, because then the foramen doesn't change. But if you change it from its axis, then the foramen is going to be pulled. It's going to move. Otherwise, you would have ischemia on all teeth, which is not the case. But we see that there are teeth where the apex doesn't move and the tooth tips, and sometimes you have things that are annoying when you have to do a root canal treatment 20 years down the line. So we see we have some activity here, and Amaski would say that there is a drop of the dentinogenetic activity, and we tend to see that we have teeth that mineralize rather than demineralize, which is interesting. I don't understand why we get that, but another paper here, and this is the labiolingual expansion appliance, and I don't really know what that's all about, but he showed here that there was a tipping motion on the apical third sector, which increased the pulpal degeneration because you had a modification of the blood circulation. This is microcirculation. There was Kim Zimutin, who does apical surgery now, who was really looking into pulp micro blood circulation. These are difficult to access. We are in the middle of a mineralized tissue, and so to have a blood flow in vivo, technically speaking, that was actually quite complex. And so on the orthopedics plan, I don't know if that makes sense, but as he would say, let the pulp breathe. So take your time. And there's some papers that show that at that point you would also activate a number of types of resorption if you go little by little rather than in one go. So I find 364 of those reviews, and this one is a little bit more recent, 2015. And what's interesting is that they brought out all the different studies. And it's kind of a conclusion. You see here that there's a change of the cytokines of the overall environment, but the conclusion is that there is no scientific study that shows that there is an association between the orthodontic forces and the dental pulp. So yes, you destroy the pulp, but it doesn't seem to have a consequence, so that's fine. But just the fact that you know, when you give a bit more talk, from 20 to 80, I don't know really, but sometimes if you know, maybe you can understand things that are happening that might be a little bit surprising. Now, coming back to the dental pulp, and this is where I say there's a lack of understanding from the previous paper, he would say that you have a drop of dentinogenesis. And what we see, however, is that when things go bad after a trauma or after orthodontic treatment, we see that we have an increase of the mineralization, which means that teeth look a little bit like this. This was before the treatment, and why one tooth and not others? I don't have the answer here. And in my practice, I used to see this a lot. Now that I'm a normal dentist again, I can see them a lot as well, but I don't have an explanation. It doesn't mean we have to do a root canal treatment. And here, this after kind of soft treatment, I think it was just a normal alignment. I'm not sure what it was exactly, but why does this tooth look like this? Was it hit? Did it get a trauma during the treatment? Or maybe when the arc was activated, there was a shock on the tooth that led to a microtrauma. I don't know. But in the end, these are things that we find, and quite spontaneously, we don't really have explanations. The second explanation, or the second observation that I have from my clinical observation, and this is quite recent, and I think it's linked to the development of orthodontic treatment with adults, because 25 years ago, when I started working, there weren't very many of those. those. And now I feel that it's a lot more common, and I see a lot more people wearing braces in the streets, and sometimes they're hidden inside, so you can't see them, but they're there, nevertheless, lurking. So on these patients, you see this, you see those pulp stones. And this is something that we had with people with bruxism or people with occlusion issues. We still see a few, but here you can have some pulp stones that are quite major. Why am I talking about pulp stones? Well, because it's something that I know a little bit more about, because for 3 years now I've been trying to understand where those pulp stones come from. These are bothersome for us because it's an extra bother to reach the root canal, so we get them out, we take a photo, we are very happy. But really what we note is that these mineralizations are never attached to the walls. That means that the endodontic are not concerned by this. It's nothing to do with them. It's an intra-pulp mineralization. So I was interested in those, and I thought, is it dentin? Is it bone? Is it stone? Do people eat stone or eggshells? And really, it's a structure that's very close to dentin, but it's a bit more like bones. You have to be a bit crazy to go and look at pulp stones under the microscope. But anyway, I'm taking a treatment for it, don't worry. And what's interesting is that you get phosphocalcic peaks that make it close to dentin, but it's not dentin. When you work at university and you're a researcher, you need to find things when you do research. And I thought maybe the pulp cells that are inside the pulp, they're not odontoblasts, they just make the dentin in those, but inside you have the pulp cells. And my hypothesis...
Juste un petit aparté, en fait, quand j'ai fait le génie SEMU, je trouvais ça génial. Je me on prend pour un génie.
I thought people thought that I was a genius, and then I realized it was the name of your bracket. So anyway, so it was a bit difficult for my ego. Right, so my hypothesis was to say that those pulp cells that have that come from the neural crest, it's the same origin as the facial bone originally. And these cells can mineralize, but they stop themselves doing it. So they're very classy, and they have this kind of inhibition phenomena. And what stops this inhibition is if you apply the biomaterial, or because you have an inflammation process, the bruxism, for instance, or those dentine irritation with amalgam, composite, and so on being applied. And as I said, people with bruxism, because you have this mechanical stimulation, and it's basically a bit like an orthodontic movement that's applied to the teeth. So the odontoblast captures the information. It doesn't necessarily react, but it transmits the information to the pulp. And from that information, and here we could put the force or the mechanical constraints that are applied by the orthodontic treatment, and that could cause the cells to mineralize. And this is why we call it osteodentine. It's in the tooth dentine, and osteo because the cells are inside bone. So is it dentin? We don't know. But the fact is, it's an abnormal reaction, and it's on the border of cell death, and it's a bit like the cells created their own little box to die quietly. Right, I've got an hour and a half to explain all that. That's brilliant, because I'll have lots and lots of time. I know we are not eating today, it's a shame. So what's the impact? Well, the impact on the pulp cells exists, but we don't know what it is. There is a clinical implication, but it's low. But what I've understood this morning is that your concept and your techniques evolve, and really you have to be careful, because the simple fact of changing concept could have some repercussions. Teeth are organs that are extremely susceptible. I always talk very gently to my teeth before I anesthetize. If they're not happy, they'll react, and they'll not react nicely. And the literature is not really relevant. Maybe there's a niche, maybe I'll go for it, but overall, that's what I had to say. So not much. There's something going on, but we don't know what. Secondly, what I wanted to talk about was also root resorption, because when you do your post-treatment panel, we say, okay, we have a malformation, maybe we had a wrong angle, but no, there is a clear resorption here. Sometimes in endo we put the cone the other way, but no, there is a clear resorption. Is it a problem? Well, if it's just there, that's okay, but sometimes it's just against the gum, so yes, that's a problem. And sometimes it's not your fault. The only thing that we could accuse you of is not having stopped the treatment on time. That's the only thing that an expert could say, a legal expert could say. Well, you could have asked to stop the treatment before. And I went to a conference of an orthodontist about 15 years ago or 20 years ago at the SFE, and they showed cases, and he'd had this once. He then bought a cone beam for retroalveolar, and every 6 months he would take an X-ray of the central incisors, and when he saw that there was a resorption process, at least he could inform the patient and he could stop the treatment when it was necessary. So Transtadt is an endodontist who did a study in '88. He worked a lot on resorption, and he looked at apical resorptions, and yes, he saw that there was an impact of the orthodontic forces. Nearly 30% of teeth that went under orthodontic treatment had this resorption against 3.4% for control teeth.
So there are several explanations. Once again, I won't go into the details. Inflammation due to orthodontic treatment and resorption due to orthodontic treatment, you know better than we do. It's mostly at the surface. When you move, when you crush the cementoblast, it dies, and it's the only thing that can protect the osteoclast. And so an osteoclast doesn't make a difference between dentin and bone. The only thing which will prevent it from eating the dentin, it is because it is protected by the cement. If you remove the cement, the osteoblast does make a difference. And that is what is difficult for us, identifying the dentin in a petri dish. Is it dentin or bone? If you put dental cells, you will say that you produced teeth, and vice versa. So you had things that you thought were specific. Well, no. You find these elements in both tooth and in the dentin and the bone. In the tooth, there is no osteoblast. So you have resorption and nothing. So you have limited resorption. It's not just replacement resorption. When there's limited resorption, it fills it up. And that you will never see on the X-ray. You see what is mineralized. Now, when you start to see this is not, in fact, not a problem. It has stabilized. There's been a resorption process which was stabilized. That you will see on the X-ray. You will see that it is stabilized, that the bone is growing back, and if it is stabilized, there will be cementum. And that's why we're told you should put calcium hydroxide. But if the cement is gone, you can put whatever you wish. Resorption will continue. Where does it come from? We don't know. Is there a genetic profile? We don't really know. There are some people, American endodontics, who tried doing orthodontic treatment. On the long term, we don't know what happened with the cancer, intestinal cancer of these patients. Well, there was an inhibitive effect on the pain, on the resorption. Well, if you give these patients 2 years of treatment with NSAIDs or whatever, well, it shows that with NSAIDs, you're able to stabilize the process in these patients who were getting those for cancer. Now,
c'est une conséquence du déplacement, il y a une compression.
there is compression. Cementoblasts don't like it. If they die and the cementum disappears, resorption takes place. And the aggressiveness of the process is difficult to forecast. It's not predictable. And there are major individual variations. There are patients who will never see anything happen, and other patients where things happen. Is there a genetic component? It's difficult to say. There is one study that I found with MMPs, but you have so many MMPs all over the place that it's sort of easy. They went and looked at rat molars to which forces are applied. It's a good model because the roots diverge, and you have areas of strong compression or less compression. So on the same root, you may have different levels of repercussion of the force. And they showed that there's an influence of MMP1 and cathepsin K. Does that mean that we're going to be injecting MMP1 and cathepsin K into people to prevent root resorption? I think things should be seen in perspective. Now, this I like less. This is not of mechanical origin, and this is typically a coronal resorption of a central incisor. You see the predentin, so it indicates that it's an external resorption which is going to become internalized. The only entry portal for the osteoblast is through the absence of cementum. And so it's still very cervical, on the verge of being against the bone. And I saw a student at La Pitié debonding, and he did it, he wasn't very comfortable, and he had pliers. Now, it's pretty systematic on incisors, and I'm wondering whether when you scrape, whether you don't scrape under the gingiva. He really went for it. This student. It's a fairly brutal movement, and when you remove the cement, if you just scrape, it's a few microns. If there's susceptibility for the patient, don't be angry with me, I'm just trying to find a reason, a cause. But these teeth are doomed, and this forces us to have techniques. We have to place a flap, bioceramics. All we can do is stabilize. We cannot restore. And the other thing which poses a problem is that they can't have bioceramics at the front because they don't like that, and the periodontum won't attach to it. So these are defects of the tooth that are difficult to manage. I'm not saying that there is systematically an orthodontic cause, but this is an orthodontic student, the same thing. She had had a simple alignment, and there was a lingual problem. And she said it really happened at the same time as my orthodontic treatment. I have no explanation for this. The story is that things went well with bioceramics, we're able to stabilize, but it does pose problems. It raises a number of questions. Yeah. I'll talk more quickly, says the speaker, who is already speaking at top speed on the verge of not being doable by the interpreters. You can do orthodontics on teeth that have had a trauma. When there's been avulsion, there's a loss of the cementoblast. The cementum is no longer of good quality, and there are problems. And when you're going to be pulling on the tooth, there's more likelihood of root resorption. But basically, There is no strict recommendation. You need to agree with the dentist, and sometimes I say if you could avoid pulling too hard on the tooth, that would be better. Sometimes we wait until the end of the growth period because we know the tooth is going to be extracted and will be replaced by an implant. In literature, it's considered as a risk factor, but not a full contraindication. This is typically the sort of tooth where I would like to ask you not to pull on it. It was reimplanted, it was an impacted tooth, and this is the decoronation technique. We have in situ resorption. It's not related to the guided therapy, but this is something I did last week and I wanted to show you. Now, I have 4 or 5 slides on this teeth which have had trauma, very fine dental layer, short tooth. You can't do the Schilder technique and stuff it with gutta perca. So there's a possibility of pulp capping and hope that the pulp will survive with apexogenesis. If it doesn't survive, we do apexification. Maybe you need to adapt your treatment to a tooth depending on the shape, but that's probably what you do, and this may bother you a little more. What's the revitalization technique? This is a patient at the end of her orthodontic treatment. This was seen at the end of the treatment. It could have been seen earlier. A 16-year-old patient. We could have done apexification, and we did, in fact, revitalization, the regeneration technique. We have a healing of the bone. There was nothing here. There was just pus, and we regenerated connective tissue inside the tooth. The idea was to regenerate pulp. What do? You disinfect the canal. You find stem cells from one of the regions where they can be found, and you enrich with stem cells, and nature is such that you can put a collagen plug plus ceramic capping, and this is 4 years after treatment. Why is this interesting? Because apexification is complicated, and from a biological point of view, I'm interested in this. At the outset, we were going to regenerate pulp. And we were going to produce pulp with the stem cells. This is where we figured that, in fact, there are things in there. So it was easy to regenerate the pulp. You strengthen the tooth, you lengthen it, it's become thicker, and it's magical. But when you go and look inside, you're regenerating not pulp, but you're regenerating, as was demonstrated in this study, you regenerate a periodontium inside the tooth. So you're bringing in stem cells, you bring everything you need, growth factors, because the tooth is prepared, you put a blood clot, and you regenerate a tissue. And the only thing that regenerates is, in fact, bony tissue. You have a ligament. You're going to have cement inside the root wall, and you produce bone inside, which means that we're going to have to adapt. The forces you had here and there will have a repercussion inside, and you double the risk of root resorption. So I'll leave you with that. When the orthodontist calls me, I don't pick up the phone, and I don't call him back, because I don't know what to do with this. We were asked to publish guidelines as endodontists, and so we started working on it. And well, we didn't write anything because no one is going to take responsibilities. I've seen treatment that went well. I saw 2 cases with some damage, so I have no recommendation to give you. We don't see that every day, but this technique may be extended, maybe spreading. So Americans all have a take-home message. You probably don't talk about teeth at home. You have better things to do, so I call it the take-to-office message.
Mais la plupart du temps, c'est réversible.
And so, a dental pulp may be affected by orthodontic forces, but lesions are reversible most of the time. But the tooth adapts very well. It's a connective tissue. Second thing is, yes, you have resorption, which happens. The only thing you can do is be careful with the extra root cementum. Periodontists have a lot of problems. I don't despair. Maybe they'll invite me someday. The pulp mineralization is related to the orthodontic forces, but they're not predictable. And finally, be careful with the new endodontic procedures which are developing. You used to have bone outside, now you have it inside and out. It's a package, and thank you for your attention.